Okay, well, it's 1 minute after the hour, so happy Thursday, everyone, and welcome to today's Embrace Roybal Center webinar. I'm Nancy Hodgson. I'm co-lead of the Behavioral Intervention Development Core alongside Laura Gitlin, and we're delighted to have you join us for an important discussion on determining optimal dose in behavioral and social interventions. Today, we're privileged to welcome two distinguished speakers from Yale University who will guide us through this complex topic. But before we begin, we'll move on to the next slide. I want to remind you that Embrace, which stands for Establishing Mechanisms to benefit to reinforce the Alzheimer's care experience, is funded by the National Institute on Aging, and that the perspectives shared today represent the views of our presenting authors. Next slide. For those of you new to our webinar series, the Embrace Roybal Center aims to advance research capacity for mechanism-based and home and community-based dementia care interventions. Through NIA sponsorship, we fund rigorous trials evaluating complex, tailored dementia care interventions, and we provide educational resources like today's webinar to support researchers in developing behavioral intervention studies. Our principal investigators are Joe Gogler and Andrea Gilmore Bykowski. Next slide. Our recently closed latest call for proposals was just closed, and we were thrilled by the overwhelming response. Stay tuned for our next call that will open next summer. Next slide. So it's now my pleasure to introduce today's co-presenters. Dr. Heather Allore is Professor of Medicine and Geriatrics and Professor of Biostatistics at Yale University. She's the leader of Yale's Alzheimer's Disease Research Center's Data Management and Statistics Core, Associate Director of Gerontologic Biostatistical Methods, and has many other leadership titles at Yale. Dr. Tong is Assistant Professor of Cardiovascular Medicine at Yale School of Medicine and Assistant Professor of Biostatistics at the Yale School of Public Health. He's also Director of Cardiovascular Medicine at Cardiovascular Medicine Analytics Center. Together, they'll explore the challenges of determining optimal dose in both single and multi-component behavioral interventions. They'll discuss approaches for testing doses in the context of heterogeneity and share real-world dementia intervention examples with important implications for research. So, without further ado, I'll turn it over to Doctors Allore and Tong.
Thank you very much, Nancy. So just here's our disclosures. We do fortunately receive funding from the National Institute on Aging. Both at our Pepper Center and ADRC, and neither Dr. Tong or I have any conflicts of interest. Next, please. So basically, I'm not going to read through this whole outline, but I'll be going over the some early definitions. Then Tony's going to talk to you really about analytic frameworks and designs you might use and methods, some newer, more advanced methods, and to really understand about heterogeneity of treatment effects. And then I'll come back with a real world example that might help you really frame how you might do this. Next, please. So our big objectives here are really to describe the concept of a dose in a behavioral and social intervention. Sounds like it's very easy, but we'll see in a moment there are some complexities. And therefore, those complexities lead to make it challenging to figure out what is going to be that optimal dose for social and behavioral interventions. And then I'm going to share with you some methods that you might employ to be able to use existing information to help target those doses. And Tony will be sharing different sorts of designs you might use, and then we'll have a real world example. Next, please. So let's first start with, we know a lot about how the phases of drug development. And just like the stage model that often people are getting familiar with, but don't know as well, let's really walk through what are the phases in a drug development. Well, they start over here at the discovery stage. So they start with a mechanism. We think this cellular process does this. And therefore, we find this target, and now we're going to try and design a drug to engage with it. And it goes through these different steps. A preclinical, is this toxic? Then phase zero. So phase zero is approaching like what we might start to be considering a pilot trial in social and behavioral interventions. Can it be done? It's with a much smaller sample size. You're just seeing, can you hit some feasibility markers? Then in drug development, they're working a lot with safety and what are tolerated doses and a number of these different effects. And so they're really starting to titrate out how much, in what manner, can it be oral? Does it have to be infused? And then you get over to this kind of stage between early clinical and late clinical, where they're doing more dose finding in patients, and they're starting that efficacy assessment. And then what I think we're really trying to target with Embrace is look at that efficacy in full trials. But by that point, they've really figured out a lot of these dosing studies. They may be comparing some different doses or routes, but that's really, you're starting with a mechanism. You're saying, do I have something that can engage and modify that mechanism? Can it be done through our pilots? Can we see if it's safe? Can we figure out a dose? And now we're going to go test that. Next slide. Next, yeah. So if we're trying to define a dose in these behavior and social interventions, it sounds like it should be pretty easy. What is the amount of the intervention to maximize that effectiveness while trying to not have negative factors like participant burden, attrition? Maybe it uses a lot of resources to be able to conduct. But it's very hard to actually get that dose compared to when you're doing drug development. Things you might be considering is, what is a dose of something? Is it their frequency, say the number of sessions a person does a week? Is it the duration? How long, how many weeks or months do you have to be exposed? Is it the amount? So you might have a session a week, but how long? 30 minutes, an hour, how long? What is the level of engagement? And then you can consider reach. So years ago, Dr. Tonetti at Yale did a falls intervention to the community, to half of the state of Connecticut compared to the other half. So these were not targeting interventions. This was a system level. So what is that reach that goes out? And Embrace does look at these multi-level interventions. What is the strength of the intervention? So if someone's exposed, how much is that intervention going to change their behavior as a result? And then adaptive. So Dr. Tong will be telling us more about adaptation. Next, please. So when we're trying to define a dose, okay, you might feel like, okay, I can measure number of sessions, duration, how long, etc. But it's a lot more challenging if we're having digital health interventions or much more passive exposures. How do I actually measure that dose? And then how do I maximize this effectiveness where I'm finding that dose that I'm going to have that intervention can have the most substantial positive change on that targeted outcome. So just like in many different things, it is going to be very outcome specific. And so maybe the amount of counseling sessions might be different for different sorts of outcomes, and one has to consider that. Heterogeneity and individual differences. We know people aren't all the same. Their underlying conditions aren't the same, and maybe even the mechanism through which something might act may be more or less functional, and the intervention is trying to address that. We also have to think about time and cost constraints. So in drug development, a lot of money is put into that dose finding, and that's just not as feasible in behavioral and social interventions. So we'll talk about some approaches to help figure that out. So you want to minimize harms. Often people don't really think about what are harms, but too low a dose may not be effective. So it could be an intervention that could be quite helpful, but if it's not a large enough dose, it's not effective. Maybe the person's just not going to want to engage in research in the future. And excessively high doses or demanding regimes, you have to meet multiple times a week and do multiple things, can lead to participant burden, disengagement, and even negative negative effects like their self-efficacy and other mental health outcomes. So then we want to be able to translate these like doses into practice in a real world setting. Next, please. So what are ways we might start to go about? We want to design some research. We want to like learn. We don't want to start from scratch. What have we learned? So we can go look through using a retrospective analyses to look at completed randomized controlled trials of the thing we want to, the intervention we want to be employing, and see what was the relationships of doses and outcomes. But this may be different trials, and so we can't necessarily have be sure this is how it would work in the population we want to work with. Lots of times we really need to think about that feasibility and acceptability. And so we talk to stakeholders, we may do focus groups and interviews from patients and providers to really find out what might be achievable. And then we're looking also at what might be known about the efficacy and effectiveness. We might look at longitudinal studies to see how do behaviors naturally change over time. What might be the frequency. So if we're looking at something where we want to reduce agitation for a person living with dementia, how frequently is that occurring? What are those durations? How much are we going to really be able to change that? And so that might be what we're thinking about. Next, please. So another thing we'll do, and what we'll see in our real world example, is how to use systematic reviews to help us synthesize research findings, generally from many clinical trials. But remember, we're thinking about mechanisms here. That is the process through which the intervention should be working. So logic models and program theories really help develop a clear understanding of how the intervention is intended to work and how that dosage influences those mechanisms, right? So logic models and program theory are very helpful to clarify that mechanistic pathway, and that's what you want to test. Then, of course, through pilot and feasibility testing, as we touched on, you can also see about what people will tolerate for their behavior. Next. Other ways we can try and validate these dose efficacies is early phase non-randomized, so one-arm trials you might use. Of course, for people developing pharmaceutical agents, they're doing randomized clinical trials at multiple doses, comparing routes, and then different sort of adaptive designs, which Tony's going to share with you in just a moment. Next. So key challenges at this point, how do we measure dosage? So we've gone over that. Recognizing some of the sources that we're getting this information on dosage in the literature may not be causation, it could just be correlation. We're looking at contextual factors to really understand the mechanisms and how this could be applied. We're realizing that people differ and the systems in which they live differ, so there's going to be heterogeneity, and therefore, just like in real life for medications where we may have to adapt doses over time, we may be using these designs for social and behavioral interventions. Next. So I'm just going to give you a brief snapshot here of the break two study. And so this is breaking up prolonged sedentary behavior to improve cardiometabolic health. And this was a dose-finding adaptive randomization trial. So they had two primary outcomes, glucose and blood pressure. And what they wanted to do was determine the minimally effective dose, the lowest dose for two elements of a sedentary break, the frequency of it and how long it is, to yield improvements in established cardiovascular disease risk factors. They wanted to figure out what's the maximal tolerated dose, like how often are you actually willing to get up and not sit down? So what's that highest dose? Before you're saying I have distress. And so this is one approach. They have primary outcomes, secondary, and then some exploratory. Next. So I'm going to hand it over to Tony.
Thank you, Heather. So now in this first section, so let's start with one of the core problems in handling the longitudinal behavioral data, the time varying confounding. So imagine a patient's condition today will influence the dose they receive tomorrow, and then that new dose will influence their next condition. So this type of feedback loop means that the standard regression methods probably won't clearly separate the cause and the effect. So take diabetes as an example. So if someone's A1C rises today, and their clinician might increase their medication, but that A1C level itself is also going to be affected by the prior treatment. So controlling for it would actually block part of the causal pathway and introducing bias in the traditional causal inference framework. So in this way, the traditional adjustment methods or regression methods cannot really entangle this. So that's why where we need the G methods for this kind of problem. Next. So the G methods, where the G stands for generalization, is developed to precisely deal with this kind of looping situation. So there are two key tools. The first is the marginal structure models, or MSMs. So they use inverse probability weighting to simulate a pseudo population where confounding is neutralized. And the second, the G computation. So it models the full system and simulates the outcome that would happen after different dosing strategies. So both the marginal structure models and the G computations are very popular in practice. So MSMs are often simpler in implementation and they're more robust against model misspecifications. But G computation can also give very efficient estimates if the models are correctly specified. Next, please. So now shifting gears, in this section, we'll talk about the experimental design perspective, how to factor those in. So the MOS, or the multi-phase optimization strategy, is a way to provide a structural way to design behavior interventions efficiently. So for MOS, instead of jumping straight into one big RCTs, MOS encourage investigators to iteratively test and optimize each intervention component. So the goal of MOS is to identify which pieces work the best and how they interact, and what those and the combination of the different components give us the most effective and scalable intervention. So MOS has a three-phase process: the preparation, optimization, and evaluation. So the preparation usually builds theory and select candidates components and figure out logistics. And evaluation is basically a classic RCT process. And the key here is optimization in the middle. And there are three different stages in this optimization. Next. So here's a visual of the three stages within the MOS optimization phase. So in the screening stage, we start with the potential components. This is where we identify which elements are active and worth keeping. And then in the refining stage, with fine-tune, we're able to test a different level of combinations and perhaps maybe use some of the adaptive designs to identify the optimal dose and configuration. And lastly, we have the confirming stage, in which we test the optimized intervention in a traditional RCT style to verify the optimized package effectiveness. Next. So specifically in the screening phase, so basically the goal is to lay down foundations. So we'll start with a conceptual model. So usually it's a theory about how the intervention should work and what outcomes matters. And then we identify the promising components. They can be frequency of sessions, delivery modes, or intensity, and we pilot test them. So it's all about building the toolbox and narrow down what's worth optimizing further. So this phase give us some raw material for an evidence-driven design. Next, please. So in the next stage, it comes with the refinement, where we empirically test how different components perform individually and in combination. So factorial design is really a favorite here. So give us effective estimates of both the main effects and their interactions. So this is also where the dose findings can happen to determine the optimal frequency, duration, or intensity for each component. Essentially, so we're in this stage, we're calibrating the intervention so that both the effectiveness and practicalness are optimized for the implementation. Next. So finally, in the confirmation phase, so this is a stage very similar to our traditional sense RCT or randomized controlled trial. So in this phase, we'll test whether the optimized version of the package achieves the expected outcomes. And more importantly, so most is actually an iterative process. So even once it's confirmed, we can always look back to refine again, to go through this process again. So this structure of most allow us to dynamically develop an intervention for behavior research problems. And this is a comparative advantage compared to a single RCT. Next, please. So now let's further add adaptation to the mix and talk about SMART. So SMART stands for the sequential multiple assignment randomized trials. So it's designed to develop a dynamic treatment regimes, essentially find out the adaptive playbook for the intervention. So instead of a one size for all, the treatment adjustment will happen based on the participant's progress. So for example, if a participant does not respond to an initial intervention, so the intervention might change in the next step accordingly. So the SMART allows us to empirically test sequences of decisions, answering not just what works, but also what the best work for whom and when. Next, please. So here's a real-world SMART design example. So this is an example from Hong Kong. So it tests an adaptive intervention design to reduce aloneness among older adults. So everyone in this trial will start with a 4-week psychoeducation module, and then participants will be classified as responders and non-responders. So depending on that response, so now we will do a re-randomization where the responders will receive booster session, while non-responders will switch to a different treatment path, such as using behavior activation or mindfulness training with a motivational component. So this kind of sequential multi-stage randomization allows us to empirically build and compare different treatment regimes, and also help us to see not only whether intervention works, but also which sequence of decisions perhaps lead to the best long-term outcomes for all. Next, please. So SMART are adaptive for individuals, and there's another closely related type of design, which is called Largo, or the learn as you go design. So it will take the adaptation to the trial level. So in a Largo trial, data are analyzed after each stage, and the intervention package is going to be systematically revised based on the prior stage results. So it's a feedback-driven process. Every stage will learn from the previous stages. And unlike a fixed trial, Largo evolves and improving as it goes while still maintaining scientific rigor. So this make it incredibly attractive and efficient, especially for complex behavioral problems where early results can guide later phases. So a few things to note between the differences between SMART and Largo, because they're often confusing. So SMART adopts the changes at the individual level, where participants can be re-randomized based on their own process. If someone doesn't respond to a low dose or low intensity intervention, they might be reassigned to a high dose or high intensity alternative treatment. So SMART are great for discovering decision rules that tell us what to do next for a particular type of patient that does not respond well. So for Largo design, on the other hand, so it adapts at a trial level. So instead of adapting within a participant experience, so the trial itself learns from the results. At each stage, the researchers will analyze all the cumulative data and revise the whole intervention package. So it could involve, for example, tweak of the frequency, delivery mode, or components. So this will be a revision at a whole for the intervention. So we can think of SMART as optimizing the personalized treatment pathway, and Largo optimized intervention as a whole. So together, they move us to a more dynamic, evidence-driven way to improve behavioral interventions. Next, please. So here's how Largo works in practice. So before we start the trials, we'll plan for outcome collection stages during the trial. And at the end of each stage, we will analyze all the cumulative data and use predefined rules to revise the intervention package, like intensity, delivery mode, and also sometimes even accommodating cost constraints. So then we will move to the next stage with a refined version, and this refined version can be used within this ongoing trial for new participants or even for new future trial. So by the end, so data collected from all stages are combined to assess the overall treatment effect. So the beauty of this design is that it doesn't waste any information. So it continuously adapts towards the optimal dose or configuration. So this means that the trial design is a living process. So Largo is also particularly attractive for very expensive trials because sometimes in the interim analysis, we can probably assure that this is going to be a null effect for the trial if we keep doing this at the end. But the traditional non-adaptive trials can do nothing about it. But Largo provides a solution that meet this kind of trial, so we're able to do some optimization and improve the intervention performance. Next, please. So far we have talked about designing the interventions, and then in this next section, so we'll talk about the treatment effect heterogeneity itself, which means that the treatment can differ across different people from the analytical perspective. So there's this very important concept called HTE, which refers to the heterogeneity of treatment effect, or sometimes referred to heterogeneous treatment effect. So these type of concepts ask not only about does the intervention work, but also for whom does it work the best. So in behavioral research, the optimal dose can vary dramatically. So it can be different by different age groups, sex, gender, baseline comorbidities, health status, and also psychosocial context. So understanding the HTE helps us make interventions more equitable and precise. And also the core goals for this type of HTE analysis is try to provide personalized intervention and prevention strategies. Next, please. So these slides bring together the idea of heterogeneity, dose, and the causal analysis into a single visual framework. So the goal of this is to move beyond a single dose comparison and instead estimate the entire dose response curve. So using methods like marginal structure models or other Bayesian approach, so we can quantify how outcomes change across a continuous dose rather than just at one fixed level. So in this figure, as you can see, on the x-axis, we have the dose. For example, this could be the number of hours per week a participant engaged in an intervention of exercise. And then on the y-axis, it has the causal effect, say maybe the improvement in the quality of life or reduced symptoms. So what's important here is that this curve is rarely linear. So it's usually an arc. So meaning that the benefit increase when the dose goes up, but only to a certain peak point, and then it will start to become a plateau or even decline if the dose further increase. So there are several key concepts in this visualization. So the minimum effective dose, or MED, is the lowest dose that one will still benefit from, well, one will start to get benefit from the intervention. And the maximally tolerated dose, or the MTD, is the highest level that the burden or negative effects will start to overwhelm the benefits. And then this concept called the therapeutic window, or TW, is a range between MED and MTD, where the intervention is both effective and sustainable. Next, please. So there are several different ways to study HTE at different stages of your study. So this is a place where it's always a good idea to consult with a biostatistician on the most appropriate and efficient way to factor in the HTE in your study design and analysis. So traditionally, people often perform the subgroup analysis to test the predefined groups. For example, in example header, we'll talk about the cognitive simulation therapy. So benefit might differ by the dementia severity. And these type of designs are usually pre-specified. And so the reason why it's pre-specified is we need to reduce the type 1 error rate and reduce data dredging to make sure that the positive findings are truly positive. So we also talk about the more modern approach for design, like SMART, Largo, or MOST. So they can bake heterogeneity into the study design in an adaptive way. And so depending on the goal of the adaptation, we can choose these different type of designs. And now with AI and machine learning, even when a trial is finished or a study is finished, we can always explore the more complex pattern using the post-hoc machine learning approach to find the novel subgroups or precision medicine effects that can tailor the future intervention dynamics. So this type of idea of data-driven approach to study the heterogeneous treatment effect moves away from the traditional concept of average effect to a more data-informed, personalized, and precise medical treatment. Next, please. So now I will give the stage back to Dr. Heather Allore on the dose finding example. Thank you.
Well, thank you, Tony. So now let's try and use what we've learned so far. And this is going to be our real world example. So we're going to act like we're going to try and design one of our own trials. So let's look at cognitive stimulation therapy. And we're going to try and figure out what might be doses and how would we do that. So we're going to be looking at an approach from using existing literature. So what is this? Well, it's an evidence-based treatment for people with mild to moderate dementia that involves engaging in activities to improve cognitive function and quality of life. So it's different from cognitive training and rehabilitation because it's focused on social elements and aiming to improve domains such as quality of life and mood and function. So we've just talked about the focus, and the key principles are implicit learning, multisensory stimulation, reminiscence, and continuity between sessions. So often we're trying to say, I want to do a trial. What is the setting? Well, this has been used in care homes or skilled nursing facilities, daycare centers, and memory clinics. What's evidence-based? Well, it's a well-established intervention. It has been shown to have various benefits that we'll go over in a second. It can be applied in a group or an individual setting. It has been shown to have some caregiver benefits for when applied individually by a caregiver, and there's also a maintenance form. Next, please. So what is a very helpful approach when trying to figure out how to design your own study? So let's say we want to do this cognitive stimulation therapy. We see there's a nice Cochrane review of 35 studies with over 2,700 participants with mild or moderate dementia. This is a photo of a group in New Zealand applying this. It's been, these 37 studies are from 17 countries on 5 continents, It's mostly been performed in Europe. Now we start to see that there's a lot of variation. So the number of participants vary from over 300 to 13 in these studies. They're in these different settings. So 16 have been conducted in care homes or skilled nursing facilities or hospitals. How long should we be doing this? Remember the elements of a dose, one of them's duration. Well, these studies go from 4 weeks to 2 years. Well, what's another element of dose? Well, how sessions? How many? Well, these varied from 1 a week to 6 a week. How many sessions overall should I do? So how long should the study or trial be? Well, these went from 8 to 520 sessions. Well, how long does that take? Well, most studies were around 10 weeks with around 20 sessions. Most of them are in group-based, but there were 8 of the 37 studies for the individual form. And so were there any potential risks? What should we be cautious about? Well, they could find, some of them found that they were either over or under challenging if they didn't target the appropriate level. And mostly they were observing negative responses if they didn't get the right level of stimulation. Next, please. So is there a mechanism? Remember I said, let's start with a mechanism. Well, in this review, they did focus on, and in many Cochrane reviews, you'll see a whole section on mechanisms. So they found that it may mostly help people in earlier stages. And this seems to be through a kind of this LEAP or language, executive function, attention and memory, and perception and social cognition. So this is a science-based approach. And so remember we talked about logic models and program theory. So there's a component of generalized cognitive exercises, a component of social interaction and support, and both underpin this person-centered approach, and they come together to uphold the dignity and value of the person living with dementia. Next, please. So if we look at this Cochrane review, we're thinking about doing this. These studies are all different sizes, lengths, intensities. What did they find overall? Well, good news is no negative effects. So that some were proposed, but they did not find these across these 37 studies. And this meta-analysis found a moderate quality of evidence for a small benefit of cognition associated with it. And you can see these standardized mean differences. And for MMSE, one of our well-known cognitive measures, there was a moderate quality of evidence for about a 2-point difference between those with CST and control. So that's pretty good. There was a moderate quality of evidence for a slight improvement in self-reported quality of life. Next, please. So remember when I showed you the break two, and they had the kind of primary outcomes and secondary. So many of these studies included had secondary outcomes. So often remember, things aren't always powered for the secondary, and you have to be more cautious. But there was high quality evidence for clinically relevant improvements in the staff or the interviewers' ratings of the communication and social interactions of the person living with dementia. So this is a different sort of metric of the rater saying how is the person social and communication interactions. There were slight benefits in instrumental activities of daily living, mood, anxiety, and behavior scales, and a moderate quality of evidence that the kind of challenging behaviors were reduced, and improvement in basic ADLs. Next, please. So overall, now we have all this, and we're still this huge range. It seems like it might be something that you'd want to be designing, but still, how are you figuring out that dose? So we're trying to target like where it might be used, how it might be used. So CST had small benefits to cognition compared to just usual care, unstructured activities. So, but what is that? I'm trying to power a study. Well, it equates roughly to a 6-month delay in cognitive decline at that mild to moderate stage of dementia. So, well, that's pretty good. A lot of people, for a non-drug safe intervention that didn't have any negative side effects, that doesn't sound so bad. The preliminary evidence suggests that the cognition benefited when they were group sessions. Remember, it's also in the individual, but the group seemed to do well when it was twice a week or more. So this is getting at our dose. Then we're trying to say who, as Tony was sharing about the heterogeneity of treatment effects, that the benefits were greater when the participants' dementia was mild. So now maybe we target it at a particular group. There was not many studies, I think only 8 for the individual CST, and they really say that that we need to know more to be able to figure out that effectiveness and the delivery methods. So if you were trying to do this in a digital health or remotely provided, there's a lot of unknowns. So it'd be a lot harder to figure out that dose. And so finally, the frequency of group sessions and the level of dementia severity are going to influence the outcomes. And so that's where, using this information can help guide that dosing. Next, please. So where do we leave you here? So systematically studying and optimizing the dose of behavior and social interventions are going to help you have a more efficient. So what's an efficient study? So an efficient study is you can minimize the number of individuals and resources needed because you have a much better sense of your effect size that you're targeting, and therefore that can help you figure out the effectiveness of treatments. And hopefully this is going to improve the patient outcomes. And you're going to be able to, by targeting the people that you have previously shown to be able to have fidelity to interventions, then you're going to be able to really responsibly allocate those resources. That allows you, if you can find these effective interventions, it can inform policy and practice. And I think the area that we still need a lot of work in is around digital health. They're very hard to figure out a dose because just opening an app or engaging with something doesn't really mean that a dose, it's still hard to know what a dose and what engagement is. And so I think we still need to learn how to work with these newer technologies. Next. So we'll just summarize our key points. Really spending time when you're planning your study, trying to find the dose is going to be essential for an effective behavioral social intervention. There's multiple dimensions to dosing: duration, frequency, intensity, deciding what might be a harm that you want to track as well. We went over approaches you might use, from descriptive studies, inferential, adaptive designs that Tony was sharing. Tony went over the MOST, the SMART, the LAGO, to provide a rigorous framework for the designs of the interventions, having you decide if you need to screen, if you're adapting, and how to efficiently do this. Tony talked about the heterogeneity of treatment effect, which the key there is for whom does it work and under what conditions, right? That is critical. Often you'll see afterwards that people will hunt for those groups, but Tony laid out really how to pre-plan this. And then we just went over the cognitive stimulation therapy that sees really how this has been used at a variety of different doses in studies across the world, but really how you might make use of that evidence to help set your own dosing. Next. Here are some key references. There are additional references that have been on slides throughout the presentation. These slides will be available. I'm sure you'll hear more about that in a moment. Next. And we're happy to answer any questions. Thank you.
Oh, thank you so much. That was really wonderful. Really appreciate the comprehensive presentation. I think we've started some Q&As in the Q&A section, but we'll take some live questions. We can use the raise hand function. I guess I'll get us started. I wanted to build on the heterogeneity of treatment response, and therefore the need to balance personalized dosing strategies with the practical constraints of implementing these interventions in the real world setting. So, noting that we have a lot of junior investigators here in our meeting, what recommendations would you have for junior investigators entering the field, in terms of how you would recommend their first focusing on getting into this area? Would you recommend, for example, first focusing on establishing a data-informed therapeutic treatment window as an aim, essentially conducting like a dose finding study before moving on to other aspects of intervention optimization? Or should they first focus on like dose finding integrated into other design considerations from the start?
Well, I think, Tony, why don't you maybe put that in the context of most, because that, that screening can be used for the different doses and different components that early stage investigator might be interested in.
Yes, sure. I think my answer will be that the first thing to really think about is for an intervention design, whether or not it has a multi-component structure and is suitable for this type of adaptive design. So if yes, if like by theory and by literature, it's something that it's verified that a multi-component design is recommended, then I think if we are talking about doing a trial starting from the very beginning or doing an intervention design starting from the very beginning. So we are likely going to go through this most process as Heather just mentioned. So we'll start from a very small pilot and also summarize the findings from the theory and refine a few intervention components and do a small pilot that using factorial design to test their main effect and interaction effect before bundling them together into an optimized intervention. And in this process, let's say if dose is a very important feature or dimension in those components, we can do like something further to optimize that as well in this process. And I think this is like a very typical process for the intervention design in the behavioral related interventions these days. Thank you.
I'd also be looking at, the literature. So where are you getting your idea for the intervention, right? So if it's all de novo, so brand new, nobody's ever done this, you really have to start at that pilot state. So kind of that, stage 0 and stage 1 to see, can this be done? Can you measure outcomes? Can people adhere? Are there barriers for the system in which it's applied? So if it is something that has been previously shown to be effective, but maybe you're, say, moving it from cognitively intact older adults to those persons living with dementia, then maybe you have to see like, well, what, is there a mechanism that I think is going to be different between them? So if there's a learning or certain cognitive skills, you really have to think, is that mechanism going to work the same way? We could look at the US Pointer trial where there was exercise and diet and also group activities built into that, right? So then we could say, okay, well, maybe I'm going to, Pointer was with cognitively healthy adults. Maybe I'm going to try this in a different setting. They were community dwelling. Maybe I'm going to see, well, can I do these components in long-term care facilities? How would that maybe change, right? So we could say, well, here are effective things. Pointer is part of the larger finger family. Many things have looked at exercise and nutrition. What if I simply could first start with just changing nutrition throughout the whole facility? So really looking at those elements, measuring things along the way. Do you have to have a Mediterranean diet for every meal? Or it could be one meal a day, right? Because if people stop eating, they're probably not going to do well. Anything else?
And now let's move on. I see Nicole Fowler posed a great question about interventionist effect in measuring dose. Is there a role for interventionist variation in measuring dose? I see Tony starting to answer the question, but Tony, I don't know if you want to sort of
Yeah,
answer
Tony, I
here.
think this is kind of along your adaptive designs.
Yes. So first of all, I want to say that so I think it's been recognized for decades that in the treatment delivery, because we have the interventionists who have different backgrounds and different years of experience, perhaps they're going to be influencing the treatment delivery and also the eventual outcome, um, effectiveness in the outcome. So there's a type of design in clinical trials called individually randomized group treatment trials. So it's a very general type of situation where we have this like clustering by the treatment delivery. So and of course, so there are always standard way to factor in those factors, the interventionist background and years experience in the modeling and also in understanding the heterogeneity in that process. And if we think that understanding a role-specific dose response curve is helpful, we can always stratify the role of the interventionist and situate that into the dose response curve type of analysis. So that's possible, but my sense is that those kind of variability sometimes are not the kind of like the wanted or planned variability. So we kind of want to monitor those more for the quality purpose, and we don't a lot of times we don't want to allow like a different optimal dose for different type of people delivering a trial. We probably want to more kind of like standardize them in some way, and that's more like an implementation research problem. So.
Mm.
And remember, when Tony presented both the Smart, MOS, and Largo, everything is pre-planned, right? And in Smart, you have this re-randomization, right? So those Smart designs were first developed all around mental health, where you just couldn't have these people with very worrisome mental health disorders not receive some sort of treatment when you could measure at a pre-planned time point that it wasn't working, right? So these were, I have, just like a physician would try something else to try and help the person, because there you have to have an ethical side of all these designs. So SMART came out of, I can't let someone fail just because, oh, well, you're in the control arm, too bad for you. So we have to build a lot of ethics into our social and behavioral designs. But these are the non-responders in those are re-randomized to a priori decision to try something else that was thought of ahead of time that was instituted to be able to help them.
Mm.
And with the LAGO, as opposed to the individual with these planned randomizations to something that could be beneficial, the LAGO is the whole project. Maybe they're going to drop an arm, change a dose, present something maybe individually that was in a group setting, vice versa. So that's also systematic, the way they're making changes, and they have a pre-planned protocol. So it's not the individual interventionist saying, oh, I think Heather should have a little more of this, and oh, Tony doesn't need as much as that. It's really very systematic.
Thank you. We have 4 questions in 4 minutes. I do want to remind people that this will be recorded and on our website, and that we will be sending a survey asking you for your feedback. Please check out our website. This will be posted in about a week, this recording, but other information on our website. Please also contact us at the email posted here if you need any follow-up. So one was about where can we seek funding for this type of research? Are there specific funding opportunities or agencies that are dedicated to dose-related investigations?
Well, I think it's not necessarily dose-related investigations. I mean, we could basically any of the National Institutes of Health. They, you can have a control versus an active arm, right? And then have these modifications. You can have comparative effectiveness research where you're having cognitive stimulation therapy against something else. And so you can have more than 2 arms in trials. You could have arms where, say, well, we'll just take Pointer. You had exercise only, the dietary component and them combined, right? So, there's Pointer itself that was largely funded by the Alzheimer's Association with support from the NIA. So there's many different ways. The thought is more about these are designs that help you figure out what the dose should be so that it can be implemented in that stage 4 and implementation research so it can be adopted.
Next question was around ecological momentary assessment methods for examining dose response and heterogeneity of response, and your thoughts on that particular measurement approach.
Tony, would you like to handle that?
Sorry, this is a question about the ecological
Yes.
Momentary assessment
momentary
methods to
assessment.
examine. Mhm. Your
Um,
thoughts on that approach, yeah.
yeah, to be honest with you, I'm not very familiar with the ecological momentary assessment methods. So,
It's a little, that it's I would say what you want to be doing, everything Tony and I have been talking about are pre-planned and randomized.
Mm.
And so we do suggest you can use some observational data to kind of give you starting points for dosings and components. But, this is focused on pre-planned assessments with pre-planned follow-up time points.
Thanks. One more oh, I guess we're at our time. So I'm sorry, Katie Abbott, that we weren't able to get to your question. We can hopefully share it with our guest and they can get back to you about that question. We touched on it a bit about the clinician's judgment and gouging dose response. I think Heather was referring to everything being relatively pre-planned.
Yes.
And so I think we touched on the answer a little bit, but thank you, everyone. And again, thank you for the excellent questions that you posed. And thank you again to our guest.
Thank you. Bye-bye.
Bye-bye.